Last talk of the day, Dr. Barbera. Those of you who know Dr. Barbera, and these are coming, his direct words, he's the coolest doc in the United States. Coolest doc ever. But anyway, medical school in Brooklyn, and then he did his internal medicine at New York University, where he was chief medical officer there. Did his cardiology fellowship and EP at Texas Southwestern, and was practiced at the largest EP practice in the U.S. down at is it Texas Cardiovascular System? Okay. All right, and then we managed to talk him and his wife to move out to Rapid City, and him and Dr. Levine have been extremely busy since that time, building a very impressive EP practice here, and he's going to talk to us about great cases from great places. Sam.
All right. Tough act to follow, neuroraids, neurointervention. I was in their lab yesterday, and wow, I felt underdressed. It was such a beautiful lab. I should have brought a black tie, I think. We're going to try our best to work through this talk relatively quickly, as I was told that we kind of have a sweep-up situation here. So I'm going to do my best, but I really don't want to go too fast because EP is, it's really, you know, something that you got to kind of focus on, and I wanted to kind of get a chance to bring you in the lab and get you to see what we do in there by describing our work. And our work is a real team job, and that's why I really wanted to promote our lab crew, who does such an amazing job, in our office group too. And I'm going to just see if I can move into this. This is our office group, and it's great cases and from great places, but it's also a lot of great faces. We have just an amazing group of people that help us with the patients every day, and it's just been a great team effort. And so I just want to make sure we keep in mind that there's not just me doing these cases and Ethan Levine. We got a great group of people, and I'm going to start with some cases. So and I'll try to work through 3 of them. But we'll see how time goes. The first case is a gentleman who is from Rapid City. He's 36 years of age, and he has a history of attention deficit hyperactivity disorder, and he's on Adderall. He's got recurrent palpitations for years, but a lot of people thought, well, it's just probably related to his stimulant that he takes to keep him focused. But then he showed up in the emergency department with severe palpitations and was in a Y-complex tachycardia that looked like that. And even the EKG artificial intelligence is pretty smart. It said very high heart rate. So you look at that, and they had him in the ED, and they saw the Y-complex tach, and they tried some lidocaine and didn't do anything. And then he got cardioverted. And I think that the important take-home teaching pearl here on this case is, if you have a young person with a Y-complex tachycardia, doesn't have vascular disease likely, nothing really that goes for that, think about the possibility of SVT with aberrancy, or even in this case, possibility of antidromic reentrant tachycardia. So if you remember, last year I gave a talk on SVT versus VT, so I kind of stole this slide from last year, but I don't expect you to likely remember it. But if you looked at that talk, you'd see that we look at criteria to try to decide with Y-complex tach whether it's likely to be VT or SVT with aberrancy. And an easy one is looking at AVR. If you see a positive R wave in lead AVR, that's very likely to be VT. Just all R wave, probably it's VT. In a case like this, you don't quite see an R wave. There's a little Q before the R, so that doesn't work for it. But this positive precordial concordance or any precordial concordance can help drive you in a direction. Usually, if there's precordial concordance, which means across all of the precordial leads, V1 through V6, if everything is either negative or positive, you're likely to be VT. If it's all precordially negative, it's much more likely to be VT. And if it's all precordially positive, it's likely to be VT, but there's one out, and that could be antidromic SVT. And I'm going to show you that path now, because that's what this gentleman had. The antidromic wide complex tachycardia that he had, that he was providing in front of the ER people, was taking a route that's interesting. It's not very common to see, but he did this here in our ER, where he came from the atrium with his extra electrical beat. His PAC conducted down a bypass tract and across the lateral wall, in his case, of the left ventricle along the mitral annulus and down to the left ventricle, where the electrical activity then turned around and head back up through the His-Purkinje system and into the AV node and back to the atrium and going around that way. So the ventricles were being activated with what we would call maximal pre-excitation. The widest as it could be, it's like he's being paced from the lateral mitral annulus. He's got no normal axis conduction of electrical impulse. So once they shocked him back in sinus rhythm, they could see that he was a wolf in sheep's clothing. I mean, he had WPW. He had a short PR interval and a delta wave, which you can look at it. It's kind of, I hate standing up here because it's, but if you look at, for example, lead V2, you can see in lead V3 a little bit of a flare on that on that QRS and a little shortening of the PR interval. Here you really see it in V4 and V5. You see that just it really has a delta pattern to it, and that goes for this being somebody who, when you put the whole thing together, is going to have that accessory pathway, a young patient who comes in with a wide complex tachycardia. And when the patient is in sinus rhythm, the reason why it's not as wide as it was during the arrhythmia is that there's a competition going on between electrical activation through the normal AV conduction axis, the AV node His-Purkinje system, and the accessory pathway. There's a way down. There's two different ways down. It's kind of like you got a bridge you can take to get into the city, or you can take the tunnel is the accessory pathway. The big wide open bridge is the AV node, let's say. And if you're up close to the bridge where you release, where you're driving, you likely are going to, most of the traffic's going to flow down through the bridge. But some are going to try to get it there a different way and take the tunnel. And the activation of the ventricles is going to be partially excited through the tunnel, through that accessory pathway. The AV node, it's designed to slow down the electrical signal from the atria to the ventricle, so the atria get their chance to ignite and to contract before the ventricles. So the accessory pathway doesn't have a slowdown, though. It zooms right through. So there you're going to see that delta wave, and that delta wave, what that represents on the PR segment, you're going to see that's the traffic coming through the accessory pathway. And if the accessory pathway were on the right side in an example, you'd see a bigger delta wave because it's closer to where the impulse starts in the sinus node. This creates a little bit of time, which allows a smaller delta wave. So that's why that patient, you didn't see a huge delta wave, and it suggests the possibility that this may be on the left side. And the funny part for me to think about in the case when I saw him was, wow, left-sided bypass tract is rare to get that and have antidromic, because antidromic tachycardia, although is very rare to begin with, it's really rare to see left-sided antidromic tachycardia. You must have had a left-sided PAC that was close to this bypass tract, and it ignited and it got back through the node, and he went off to the races that way, and it's just less common. So we see incredible cases here. It's an amazing place. I never knew that I was going to see so much pathology, but it's here. This is just a nice, thoughtful image creation of where bypass tracts live based on case series. So these are our, tricuspid valve and your mitral valve. You have a coronary sinus that lives underneath in the AV groove. The mitral valve, it kind of travels right around it. And in the mitral annulus and the tricuspid valve annulus, these are where these tracts live. They come off of the rings of the AV valves. And the majority of the conduction of the accessory pathways are actually left-sided, left lateral, and left posterior pathways. But there's a fair amount in the posterior septum here, in the bottom between the mitral and the tricuspid valve. And occasionally you get some zebras where they are these lateral right atrial to right ventricle connections. But like I said, the majority of the time they're out over here. So in this patient, we brought him to the EP lab because we really were fired up to get him fixed. This was a nasty arrhythmia, and it was bothering him. So definitely WPW, by the way, you kind of, even if it's not happening that often or bothering that much, you still want to think about the other possibilities with WPWs. It's not just about symptoms, but there is an increased incidence of sudden death with WPW. So you want to figure out whether this person could have a high-risk accessory pathway. And one way to do it is with treadmill testing. And if you see a rather abrupt drop from the delta wave to no delta wave, that can be helpful if it happens at low rates during the treadmill test. But if you see a gradual change in the delta wave being lost, it may just be all about that competition and adrenaline tone through the AV node. So you may not know with exercise treadmill testing whether this patient can carry a rapid signal. The way patients with WPW have sudden death is they can go into AFib. They have a much higher incidence of AFib because of this electrical extra connection. And atrial fibrillation, as you know, the atria is signaling at 500 or so signals a minute. So if you conduct anywhere as close to that, you can cause the ventricles to fibrillate by stimulating it with that kind of atrial fibrillatory excitation if the pathway can take the signal down that fast. And the thicker the band of the pathway, the more likely they are to do this. I use the analogy of pathway looking like something like imagine a guitar string, and they can be real thin strings that are, I guess, are like an E, or they can be the thick B chord or something, So the thicker, the more likely they are to conduct rapidly. And those are also harder to cut through with ablation. So here in the lab, we bring in our catheters and we start doing EP testing. And this is a ablation catheter, and up here you see the surface. Try to orientate you guys a little bit into what we do. And inside that we have good amplifiers and filters, and we really try to get a look at what's happening along that atrial ventricular pathway along the AV node and His bundle. We put this ablation catheter right where the His catheter should be, and we look for an atrial electrogram, which you can see here, and you see the P wave on the sinus right above it, and then you see this little Sharpie, and that's the His bundle signal. And then you see the big V, which corresponds with the ventricular. And this is sinus rhythm with the HV. Now, what we measure is the HV interval in the lab right away. And we can tell, wow, look at that, just like we thought, this guy's got a 0 millisecond HV interval. For the time from the H to the beginning of a QRS, where the delta wave is 0, because he's already heading down through the bypass tract. So no big surprise, but I just want to kind of warm you up a little bit. This is a little bit more of a way of orientating you guys to the inside the lab. This is our 4-chambered heart, and we're going to bring catheters in, and we need to put one usually down in the right ventricle, in the right ventricular apex. We're coming up from the groin, and then we're going to put one along the coronary sinus, and that's going to run all around the mitral valve with a lot of poles on it, so we can measure electrical activity along the line of the mitral valve annulus. And then we usually have a catheter up near that His bundle by the AV node. And these are the fluoro images of such catheters. There's also usually one up in the high right atrium along the AV node. There's our RV catheter. We're looking at this in an LAO image, and we can see the coronary sinus catheter out along the mitral valve. So then we start pacing, because we really like to manipulate the electrical activity in the heart when we get in the lab. We want to see what's going on, and the way we investigate is by pacing. And we start pacing the ventricle here, and what we see is in the coronary sinus, these yellow tracings. By the way, the red is the RV catheter. That's pacing. See the pacing stimuli, this little stim. You see it along the ablation. You see it along the RV. You can even kind of see it a little bit in the yellows as that electrical artificial stim is kind of loud. It breaks through everything, including even the surface usually. So you see this big surface QRS. That's just pacing the ventricle. There's nothing abnormal about that. That's us doing that. And when you really want to focus in on here is the coronary sinus, because that's our real telltale about what's going on. We said most of these bypass tracts are on the left. We anticipated this patient's tract would be on the left. And what we see here is in the coronary sinus, two signals, because we're half atrial, half ventricular running along the mitral valve annulus. So you get two electrical signals. You get a smooth ventricular signal, and you get a sharp atrial signal. And we see something called eccentric activation immediately here, telling us this guy's problem's on the left side. Because if you look at the V, which is the smooth, to the A, the atrium is activated most distally by our just assignment. We call CS12 the most distal pole, the furthest to the left. And as we go up, we're becoming more proximal or coming back towards the AV node. So the electrical activity is making its way backwards through that marching process. Now, while we're in the lab and we were doing we were actually in the process of going transeptal, the patient did us a favor. They went right into SVT. But this time, he went the opposite direction. What happens here is he's in sinus rhythm here, and then there's a premature atrial complex. You see the sharp CS electrical action. Before, you see the P waves. You see P, QRS, P, QRS. And then there's a P, this is a PAC happening. You don't really see it that well. That's typical. That just shows you what happens on surface telemetry. You don't get a great look. You try your best. But then you see a little bit of a stretch between the A and the V. Notice the A and the V's were right on top of each other during sinus because the guy's got both Parkinson White, so they're really close to each other. But he has this PAC. The PAC, the premature atrial complex, when it happens, the AV node doesn't want to take that signal. It slows in conduction because it's premature. It's called decrement. The more you hit or more quickly you ignite or stimulate the AV node, the slower it conducts down to the ventricles. So what happens is there's more time for the signal to run through faster conduction fibers to get to the left side, to go down that bypass tract, and then ignite the tract and go up through the tract. Go down. It goes down the ventricles. The tract, it's blocked. The PAC. That's what. I made a mistake here. PAC happens. Tract blocks. Didn't conduct. Goes down the node, but goes down slower. Then he comes through the node, the His-Purkinje system, and it gets to the tract on the other side, on the ventricle side of the tract, and it goes backwards up the tract. So this is the opposite. This is not antidromic. This is orthodromic, we call this. Now it goes to the tract, and then it's in the atrium, and that's the atrial signal. You don't actually see a tract signal. And then it's going down to the ventricles and up the atrium. So we have A and V right up on top of each other here because we are now conducting down the AV node and back up the tract. I'll show it better in a little bit here. So if you looked at it on this tracing, you could see that there's a V in the coronary sinus. These are coronary sinus signals. And there is an early atrial activation out here where there's retrograde conduction going up through the bypass tract. Then it comes back down through that AV node and then up through the bypass tract, and you're off to the races in this orthodromic AV reentry. If the patient had normal conduction and the catheter in that mitral valve coronary sinus area, if they had normal conduction, this is called concentric activation retrograde. You see the CS activation pattern retrograde is normal, proximal to distal. That's the way it should be. This is a look at that orthodromic pathway in another patient, but you can see here there's a narrow complex tachycardia, and the A's are kind of a little bit out into the QRS, more than you'd see in AV node reentry, and this patient ends up having orthodromic reentry, again, like the one I just described, going down through the node to the ventricle, back up that bypass tract, and to the atrium back down. So they're off to the races like that. So the two different types of accessory pathway arrhythmias, as we described, are the wide complex ones, which are antidromic, and those are zebras. They're rare. This is the much more common bypass tract. By the way, of all SVTs, WPW makes up about 30% of the SVTs that we see. Now, to get to this tract, we have to figure out how we're going to get there. We can go two different ways to try to go and ablate it. One way is going up from the right femoral vein through the IVC to the right atrium and across the foramen ovale and across the left atrium to the lateral left atrial mitral annular section where that bypass tract would be. And this is the transeptal approach, which we chose in this patient. And this is another way that a lot of people used to do more of, we do a lot less of, would be going through a right femoral artery approach through the aorta, up around the aorta, and we call that retrograde aortic approach, into the dip across the aortic valve, into the LV, and across over to the mitral valve. So two different ways you can get there. Both could fix the patient, but getting through the femoral artery is always a bigger potential complication. Actually, it's easier to do it transeptal, believe it or not, than it is with the femoral artery. Because you get with the femoral artery, these patients are always heparinized during the procedure. You've got a 8.5 French sheath in the femoral artery, and just a longer hold that slows us down. Brandy gets mad. Where are you, Brandy? She has to hold the groin. All right, so transeptal access. So we use ICE to do it. We have an intracardiac echo. That's cool. I like to call it ICE. It's cool. So you've got a catheter in the right atrium that is it's an echo catheter, and we are looking across the foramen ovale from the right atrium, and we see the septum, and it's tenting because we have put a catheter from the right femoral vein up to the foramen ovale, and we're now tenting. Right there's the tent. And that's a look at the tent that you see on ice. And then when you see that, you know where you are because you kind of look across pulmonary veins. You know you're not too anterior. You can kind of you don't want to poke anteriorly because the aorta is there. So you stay away from that. You don't want to have to call Dr. Mungara. So then you kind of punch through. You have a radio frequency ablation wire that you just come on, and it punctures this little, very thin membranous foramen ovale, and then we just take the wire out up into the left upper pulmonary vein. These are the pulmonary veins in the back of the left atrium, and then we can just track over that. So then we're over there. But of course, heparinized the whole time. So it makes it a little bit more, when I was a fellow, I used to worry a lot more, oh gosh, I'm heparinizing and I'm going to punch through the foramen ovale, but it's actually a lot safer because you're much less likely to have to call the interventional neurologist, neurosurgeon to fix your stroke problem if you don't heparinize, because you'll get thrombus on these wires and catheters if you're not heparinized. And we run ACTs pretty high, 350 to 400. So, okay, here's a look quick at the 100 sweep speed of that tachycardia we saw before, and this patient is in it, and we are getting ready to really home in on where it's coming from. And what we do is we try to push that coronary sinus catheter way up past the bypass tract, and we want to bracket it. We want to see is the earliest signal in the middle and the later signals on either side, so that we know where it's earliest. And we can even mark that with our three-dimensional mapping system and just go burn there. It's really burn by numbers or paint by numbers. And this is us trying to get the right location. we've got, if you look at this right upper, you're looking at an RAO look. It's the football on the side, the heart, and this is the atrium, and that's the ventricles, and this is the coronary sinus, and the bypass tract runs somewhere along there laterally. It's usually going to be out over here. If we look at it LAO, it's going to be out here. And this is just a look from the rooftops of the atria into the valves, and we have from the ventricles, mitral and coronary sinus. So we're from the ventricles looking LAO, and this is the tricuspid valve. So if you looked at it on fluoro, you'd see some transseptal catheter and coming across, and what we're trying to do here is get on the valve annulus. That's where we want to burn. The electrical connection, we don't really have an easy time burning at where it starts in the V or where it starts in the A. It's perfectly thin and most likely to be ablatable in the middle, on the aortic, on the mitral valve in this case. And so what we look for on that signal is to tell us where on the annulus, between the atrium and the ventricles, right situated in the middle, is we want to see an atrial signal and a ventricular signal. If we have A and V, and the A is sharp, the V is smooth, then we know we're annular. And so we're in the right plane that we want to be in to ablate this patient's problem. This is during sinus rhythm, so we can see it real clearly. And then we are homing in, and we're looking for that early activity. In this case, we just paced the ventricle. So while we're pacing the ventricle, we're looking for that early retrograde atrium. And you see it here, but there's still a little bit of a difference between the V, which is smooth, and the A. We kind of want to get them superimposed. There's a certain signal, we call it a Kent, and that is what this guy has now. So we're on the V, we're pacing the V, we have a smooth V, and the A is happening sharp inside the V. So right there, it's kind of like almost one mono potential of V and A together, and that would be pretty much a Kent bundle signal. There's a V and the A on the, and this upper purple line is the proximal pole of the electrode. They're separated by about 3 millimeters, 4 millimeters. So you just got a little bit of space here between these guys. This is the one, but this is where the burner's going to be. So we have to make this one perfect. But this gives us a little bit more information about where we are too, so we know if we need to move more proximally or distally on that pole. All right, I got to try to move faster. Gosh, I'm in trouble. All right, so here is the Cardo mapping system that we have in the room. So in the room, we're trying to make this map. We got the transseptal. You can actually see our catheter. We see our sheath with our system, and we can see our ablation catheter, and we can actually see our coronary sinus catheter and all of its poles. And we've bracketed where we want to be, and we just start burning. We put the burner on, and we can nail this thing if we are right over that spot. In this case, we come on with the burner here, and we are, V and A are fused here initially. The V and A are right on top of each other, right on top of each other. There's a V and there's an A sharp inside. The V is supposed to be smooth, and the A is sharp. So they're right inside each other. And you can see right here to right here, there's a change. And that's the difference between the man having recurrent arrhythmia for life and being cured. Right there. The VA here, you see the VA, they're right on top of each other, and they separate right there. It's subtle, but you see it. You can see it really well on that proximal one, where the VAs jump away from each other. That's the fix. Now we just got to kind of touch it up, make sure it doesn't come back, because sometimes if you just sideswipe, it'll go away for a little while. You'll get edema. You want to really hit it well, but you don't want to hurt. So it's like this, always this delicate balance of recurrence versus complication. I always say I'd rather have recurrence than a complication. So we try to find that balance. In this case, though, this is the 200 sweep speed, really blown up version of that VA right on top of each other, and the V and the A separated. You really see the difference here. And so that's a cure of a WPW case. And this is him with his 12-lead post, and there's no more delta wave, and there's a normal PR, and everybody in the lab is excited. We're very happy at this point. This is before, this is after. This is after as well. And if you look at this, you might want to call like a STEMI because you're getting nervous, right? So you go, what the hell is this? But believe it or not, this is almost like as smart as those neuro guys, because our heart cells actually have memory. That's called T-wave memory. The activation sequence of this patient to their ventricles was a combination of the accessory pathway going down and the AV node getting down, creating a different activation sequence for his whole 36 years on the planet. All of a sudden, we changed it. Now his activation sequence is only going through the AV node. But his repolarization process, which is a lot of ion channels have to get caught up and learn how to get back to being the normal recovery phase, that doesn't happen immediately. It's almost like a molecular thing that goes on. It's been tried, people try to explain it. It's more basic science, it's above pay rate. And I just took the EP boards and I probably got that question wrong. So, recertify. I don't know if I passed. But anyway, so this is T-wave memory, and it happens for hours. And you know, so you're in a CPU with this patient, and you'll see this, and you wonder, and you could hit a coronary when you're burning along the annulus. There's a circumflex there. There's coronaries around. So, you really want to find out how's their chest pain. And if they go, I'm having chest pain, then you go, is it hurt when you take a deep breath, or is it just a steady pressure? And that's going to help you. Obviously the pleuritic pain could be from the burn, but a steady, Levine sign, not Ethan, but yeah, that's scary. So here he is, so this was him before and after. This is him in the clinic. A month later, we see him in follow-up, and his T-wave memory is no longer, he forgot. His T-waves now forgot all about this life of WPW, and he's cured, and he's a happy camper. And there's of the devil. There he is, and Dr. Mongera. We have a big team of docs and people, Dr. Heilman, Dr. Gassmeyer. These guys really are carving new pathways, literally, with ablation. They just got a lot of promotion tackling inappropriate sinus tachycardia. So if you have an IST patient, send it to Ethan, not me. No, that's really cool, though. They're really doing some incredible collaborative work. We also do a lot of AFib convergence here that are collaborative, and Dr. Mongera is motivated and really, really stimulated by EP, literally. So this is more of our great cases and our great faces. There's Brandy again. She's terrific, but she wants me to always hurry up, but take my time, but hurry up. And there's Jenny and Charisma and Becky, and there's Gordon. He's our anesthesia. We have anesthesia is a big part of our success because they're huge with helping us with our patients. They really have a great collaboration with anesthesia. And we even have travelers like Katie. She's terrific. So we put everybody together. We work well, and 1,600 cases a year at this point, and it's a lot of hustle. It's a lot of work, but we're fixing a lot of broken hearts. So next case, we've got. I'm going to try to go really fast because Cece's going to get a hook and pull me off like late night at the Apollo in a minute here. So I'll go real quick with this PVC. So PVCs are another thing we see a lot of, like AFib, but we see a lot of these too, and they can really be bothersome. The reasons that we get referrals is when they're happening so much that they're really starting to cause a lot of symptoms usually. Or the patient's developing a cardiomyopathy. If you see some PVCs and they're feeling fine and their EF's normal, you don't need to send them. But if they're really bothered by them and they're having a fair amount of them, by ventricular bigeminy, and they're getting lightheaded from that because they're saying their pulse is 30, but their heart rate's 60 because it's a there's no arterial pulse from the PVC. That could be a reason that the patient feels horrible, and we start to try to look at where these are coming from. We can try beta blockers, they almost always fail. You try calcium blockers, they almost always fail. And then you can consider antiarrhythmics versus ablation. A lot of people don't really want to take antiarrhythmics. They have lots of issues, side effects and things. Certainly amio is not a great one for a young person with PVCs, and Then people with LV dysfunction, flecainide wouldn't be a good thing for PVCs. And sotalol is annoying because you got to deal with admission to the hospital for QT interval measurement. So, you know, a lot of times we end up, and it fails a lot, so a lot of times we end up saying, all right, let's try ablation in this situation like this. So there's a patient with, you know, from somebody from Hot Springs with lightheadedness and fatigue, and on their 12 lead, they're in Bigemini, and their echo's normal, and they Lexi-scan negative for ischemia, and they got 31% PVCs. And you look at the 12 lead, and I look at this, and I start to, I get excited. You know, I'm excited because I see, I think that's a posterior medial papillary muscle. And so why do I? Because I just took the boards and I had to know that. But no, it's more than that too, though. You really do. You know, there's believe it or not, this is the boards. So every single one of these locations in the ventricle where PVC can come from has a funky looking QRS pattern that you can know and go, oh, it's coming from there, or it's coming from this location. So this one ends up being a posterior medial papillary muscle. So that's what excited me based on, I look at the precordium, I look at the transition. If I had more time, I'd go through it more, but Cece's going to kill me. Here's the papillary muscles, look at from a nice anatomical pic. And here's the posterior medial, or papillary muscle, as you know, it's got some chordae on them connected, and they hold the mitral valve in place from prevention of, you know, MR. And here's your anterolateral papillary muscle. They tend to be arrhythmogenic locations. There's a fair amount of PVCs we see from these papillary muscles, and they're ablatable. You can get them pretty well with a transeptal coming across the foramen ovale into the left atrium, and then you're across the mitral valve, and you can get into one of these pretty nicely without having to go through the femoral artery retrograde aortic approach. So we like papillary muscle PVC. We've had a lot of good success. We do our transeptal. We have ice in there. We can actually see the papillary muscles with ice, and I'm not going to belabor it too much because I'm running out of time. But what we do to try to find out how we know we're on top of it is we do two things: pace mapping and activation mapping. Pace mapping, we go to the location where we really think it's going to be. We can use the echo machine to help guide that. We can actually see a green tip on the tip of the catheter, which we registered to the CardioMap, the electroanatomic mapping system. And then we pace from the location where we want to pace from, and we try to create the PVC with pacing. If we can make the pace beat look just like the PVC, here's his real PVC, and here's us pacing over here, you see the little stem, and that's a really good pace map. So you look at all 12 leads. Lead 1 looks like it, lead 2, lead 3, R, L, F. We pretty much we know, wow, this is like almost 100% pace map. We're getting ready to burn here. But we would like to do one more thing. We do activation mapping. It's also quite useful to know that it is the earliest signal. It's the epicenter. It's where the earthquake really started, where the PVC began. And in this patient with the posterior medial papillary muscle PVC, we see this little zzz right there. We call it right in the lab. It's a very kind of high frequency, low amplitude signal, but that is happening 35 milliseconds before the surface QRS. And if we get anywhere between 20 and 40, we are like, yeah, we're early. We're really early. We get pre-surface QRS, we're early. We have that pace map, we're getting ready to burn. And then we just want to make sure we're not near a left main coronary and things like that, which we mark with our intracardiac echo so we know we're far enough away from bad structures, the His bundle, stuff like that. I don't want to present it any M&Ms. So here we go, activation mapping. We burn. When we start burning, the cells scream before they die. They sort of let off all this this kind of crazy signal we see during it, and we know we're right on the spot. And this is our electroanatomic mapping system. By the way, that's the anterolateral papillary muscle, which we mapped on ice and registered. This is the posterior medial down here. And we burn down here. These little lesions are the burns in a RAO and an LAO look. Here's a posterior medial papillary muscle. Here's the anterolateral. And we delivered radiofrequency here, and the patient did great. He was in clinic yesterday after 1 month, and here's his 12 lead. Here's his 12 lead right after. We wait, 10 minutes or so, and if we see no PVCs, we got to go to the next case. So we move on, but sometimes it's unfair because the 3 days later they start having PVCs again. So a month later is really useful, but this person who had 33% PVCs is feeling good and probably is fixed. Great cases, great faces. Here's some great people that work with us. They're not members of they're not on our employee payroll, but they are reps from industry, and we really work with them, and they are a big part of our success. Amanda, Johnny McMacken, he used to be called, now he's Johnny McMappin because he became a mapper. He used to be our nurse, EP nurse charge. He's terrific. Carrie's been here forever. She's terrific. And Brenda's come along with Medtronic and is bringing us leadless pacing and physiologic pacing. Been great. I got another case, but I can't do it because I'm waiting for the be gonged. So I'm just going to fly through. I'm not going to show this. This was a mitral annular flutter. It would have been so much fun. I really wanted to show you this one. Maybe we'll save it for another time, another place. That's Dr. Teixeira, and he's really where it started. That's another great faces, but with masks on. And there's famous Dr. Hatton Alice. You guys got to see him this morning. We were really glad to have him back. I didn't get to see him today. I got to find him. Who else did we miss? And this is my great faces, and we are definitely enjoying our time here, and that's Teddy. And there's Mount Rushmore through that hole, and there's a rally going on. Thanks, everybody. I don't know if I have time for questions or not.
You have time for questions.
Okay. No questions?
Hi, just a quick twofold.
Hi there.
What is the rate of reoccurrence that you see with SVT ablations? How many patients do you have coming back? And also, do you ever see patients who were ablated for SVT as teenagers, for instance, that you're seeing again?
I'm sorry, that last question, can you repeat it?
Sure. If you have, how many patients have you personally seen that had an ablation done for SVT that you are seeing as an adult that have had to have it done again?
Okay. So the first question on SVT ablation success rate, I'd say it's in the 95% rate. It varies a little bit. SVT's definitely higher success than our AFib ablations and our PVC ablations. It's the highest success rate. SVTs, the majority of them are AVNRT, about 60%. And AVNRT ablation is about 95 to 98% in that range for success. WPW, the success may be slightly lower if you have a posterior septal, especially, because the septum's thick, and you can have problems getting that, and there's sometimes giant-sized coronary sinus diverticular veins that are wrapped with bypass tracks that can be tough to get. So the success rate may come down in some instances of SVT ablation when it's that. And then atrial tachycardia makes up about 10% of SVT. ATs we're pretty good at if they'll have them. If they have them, great, we're going to cure them. 5 beats of ATAC, we got no shot. But if they're living in ATAC or easily inducible, the trick in the lab with atrial tac is you got to use MAC. You can't really give them general a lot of times, because if you give them general, the atrial tac goes to sleep. So you kind of have to do a patient awake. It's a little bit harder because they move, the map moves, and you're up shit's creek. So it's atrial tac success can be a little lower because of inducibility and because of problems sometimes with the awake state. But for the most part, I'm going to say 95%. As far as the youngster having an ablation at young and then coming back with it, if they ablated it when they were young and it's gone, it should be gone. It should be a different mechanism if they come back. There's no reason why someone can't have AVNRT and then another day have an atrial tachycardia when they're 50, an AVNRT when they were 20. So it happens, it's rare, and there are failures. And there are cases that we see that the technology and the experience was less 20 years ago, and they were afraid to do it, or they couldn't get it. They didn't have a thermocool ablation catheter like we have that burns the deeper lesion. So there's a lot of little tricks that we have now and experience that we have. We can fix a lot of stuff that they couldn't do in 2000, 20 years ago when I first started. Is that Dr. Hattenhouse?
Obi-Wan. Oh, man. Sorry, I appreciate the shout
You're
out. I
looking
feel like I
great.
could pick your brain for hours, but
I love you. I miss
just like
you.
the old days.
Can you come back?
Yeah. Random question, more for like in the primary care setting or for non-invasive cardiologists would be is if you see pre-excitation on an ECG in a patient that's maybe 30, 40, 50 years old, they're slower, maybe you see one when they're faster and they're not pre-excited, would that warrant a referral to you guys if they're like 50 and you see this pre-excitation? Does that mean it's a benign thing and just leave it alone? Or
I don't know that they have to get a referral, but if you want to be able to say that you think that it's a low-risk tract, and if it's somebody who wants to fly airplanes, where's my friend Rob Santa Cruz? If it's somebody who is in a position where having this problem could hurt others driving trucks. So, you know, there's a lot of scenarios, but if you have somebody who doesn't do the high-risk occupation, who is intermittently pre-excited, it's usually a good sign. It means it's less likely they got risk for sudden death. But you might want to bring them for a treadmill test in your office and watch a abrupt stop of the bypass tract. If the bypass tract, the delta wave, I mean, is slowly going away with speed, it could be just that they're jacked up on Mountain Dew and they're going through the AV node. You know what I mean? You don't know. So you have to be a little careful. And when in doubt, I always say, send them to me, because we can look at it. You know, and EP testing, diagnostic EP testing, is very, very, very safe. It's super low risk. And you'll know when you give them isopril in the room and you pace the atria at down to 250 milliseconds. If they conduct that, that's a dangerous situation. That patient should get ablated even if they say they feel fine because they're at risk. But if they block at 300, hey, you know, even on isopril, they're blocking at 300, you're fine. You didn't induce anything, you're safe. So diagnostic EP testing, I move in that direction because I know the safety. We do it with, you know, without even using X-ray, and we're putting soft catheters up. We're not even going to the left side. We're not doing anything like that. We're just putting in some floppy catheters and doing a sleepy little 30-minute diagnostic, and we're going to know that everything's fine, and they're good for life at that point.
Round of applause.
Thank you.
All right.